I'm not going to make any more changes on lessons. It's today 3, 4, and 5. No changes. Okay. So just so you guys can get some awareness of us, and can we just get a quick check that people are able to hear us on the sophomore class? Are those guys good?
I'm checking the chat.
Appreciate you, Paige. Good? All right, sweet. All right, so I just want to give you guys a couple of quick questions. It's kind of a weird test because we're testing juniors and we're testing sophomores. As we progress through, we see more clinical vignettes. As we're sophomores, we see more first order questions. I'm going to kind of take a combination of the two. I can't completely outclass the sophomores, nor can I give you guys the progression that you're not expecting, then you get hit by a bunch of ologies. All right. So question number 1, a 68-year-old man is evaluated after an ischemic stroke. He has normal strength, normal sensation, normal coordination. When speaking with the patient, his responses are fluent and appropriate conversational affect, but consist of nonsensical words and terms. So we pretty much already have a diagnosis, right? Wernicke's? Cool. Which is the artery that's most associated with the suspected lesion? And it's okay if you guys don't know it and like rattle it off real fast, because I know we still take some time to study the slides at length, but this is kind of a softball question for you guys as far as difficulty. I like to ask second order questions a lot of times. Is this like insanely difficult, or is this kind of a reasonably, that's a softball question if we were to study the slides? Cool, love it. All right, next question. Middle cerebral artery. Softball. It'll be a softball in the future? Are we able to draw that connection that middle cerebral artery, inferior, superior branches?
We will be, sir.
We will. I know. Don't worry. Once you go through the slides, I know we don't pour over it because we're just studying for the next exam. I'm sorry, I'll give you the answers on these. All right, so next one. I got a 24-year-old woman develops a severe headache after 24 hours after a lumbar puncture. The pain worsens when she sits and stands, but improves when she lies flat. She has no fever, no focal neural deficits, or altered mental status. We've given her oral fluids, caffeine, analgesics, but it's not really working too well. And the headache remains severe after 48 hours. Which of the following is the next most appropriate in management? Epidural blood patch. Some of those look good. We're like, hydrocodone looks good in a lot of cases. Maybe a Toradol shot in the future. Am I worried about infection afterwards? No, I want that epidural blood patch. All right, I got 2 more for you guys. I got an 82-year-old man presents with diplopia. I got neurologic exam, notes that the patient is unable to abduct his right eye past midline. What structure contains the nuclei for the affected cranial nerve? I'm asking you guys to localize a lesion. Do we remember when we're dealing with the brainstem, particularly the pons, it's 5, 6, 7, 8 on that slide. It has the little ballet thing going on. Those are kind of the levels of details and localizations that I'm looking for. Hopefully that's not like this is a really scary question, but I deal with clinical vignettes. I'm looking to localize lesions, and I'm looking to apply maybe first or second order questions inside clinical vignettes. All right, last one for you guys. I got a 31-year-old male presents with acute fever, severe headache, nausea, vomiting, myalgias. Exam reveals neutral rigidity, non-blanching petechial rash on bilateral lower extremities, and a focal onset of right upper extremity motor weakness. He's alert and oriented. Head CT shows no evidence of mass effect or increased cranial pressure. Bacterial meningitis is suspected. So I gave you guys a diagnosis, and you wish to perform a lumbar puncture, and I gave you guys what we're doing for the next thing. He reports taking Tylenol and ibuprofen the earlier that day. Which of the following is the most appropriate next step? Do we delay the lumbar puncture for 7 days because he took ibuprofen? Do we delay the lumbar puncture until the rash resolves? Do we avoid the lumbar puncture to that new focal neural deficit? Do we perform the lumbar puncture now, or do we reverse the effects of ibuprofen before the lumbar puncture? So to jog y'all's memory, we talked about ibuprofen. Does that cause any effect that we're worried about for doing a lumbar puncture? No, we're talking about warfarin. We're talking about people on ticagrelor, more heavy doses of antiplatelet activity. I'm not worried about Tylenol. I'm not worried about people on ibuprofen. So you can throw some of those ones out. What are some of the indications that we should get neuroimaging before we do a lumbar puncture? Some of those are kind of baked in there, that new focal neural deficit. But in the question stem, I already gave you the CT scan. So I'm trying to trip you up and kind of give 2 different presentations. We already know the answer that everything's midline. I'm not expecting uncle herniation when I do that lumbar puncture. Therefore, we can perform the lumbar puncture now is the correct answer. Is that kind of scary? Is that like a softball question? We haven't had a chance to study the slides yet, but you guys see how I like to form questions? we'll keep working on these. It's first exposure to how I write questions, and I'll keep giving you them. If you're a little bit nervous about it because you're like, hey, those are some tough questions. Again, you guys haven't had a chance to dig through the slides the same way you do when you study for exams, and we're going to keep doing a couple of these until you guys get comfortable with my testing style. All right, so today we're going to talk about some of the diseases of the nerves. I'm sorry, go ahead. Oh, yeah. My audio's choppy. Do you want me to move this mic up? Sure. Yeah, please. Turn off the front lights. Am I still choppy or am I doing better? Oh, Manny can now manually record. Paige, can you hear me okay? 3, 2, 1.
I can't.
Okay.
I'll keep it on the chat.
All right, I'll keep going forward. If you guys aren't able to get me by the end of going through the learning objectives, we'll stop and pause. All right, so big things that we're going to pay attention to. We're going to get into some individual disease states. This is an organization that we're used to seeing in IPAP where you're like, hey, give me a disease, indications, presentation, treatments, specific nuggets I need to know about it. It's going to look a little familiar. I know the first 2 lessons were a lot of review of previous things, going through HPIs, kind of wishy-washy as far as how we ask questions. Now you guys are going to get those disease states we're used to seeing. We're going to talk about some mononeuropathies, some polyneuropathies, mononeuropathy multiplex, and then some special categories thereof. We're also going to talk about a couple of things that are hereditary. We need to pay attention to whether they're dominant or they're recessive, because that's going to tell me, hey, 1 for 1, I'm expecting this with parents or versus not. And I have Charcot-Marie tooth disease that we're going to talk about, hereditary sensory neuropathies, family amyloid neuropathies, and Refsum's disease. We got a couple of inflammatory diseases we're going to talk about. I know it's a very long list, just kind of chunk them into these groups. Guillain-Barré's is very common. There's a lot of test questions that are based upon this in my test, as well as for the PANCE, as well as in real life, you're going to see Guillain-Barré in your patients. I've got chronic inflammatory demyelinating polyneuropathies. I got multifocal motor neuropathies. I got neuropathies associated with monoclonal gammopathies. That's basically, hey, I got some people that may end up with multiple myeloma. What are some of the neurologic symptoms I can see from that? And then I got some vasculitic neuropathies. And lastly, I got a couple of things that are going to affect that neuromuscular junction. Chunk these together. We'll show you how to separate them. But if I'm thinking neuromuscular junction, I'm thinking myasthenia gravis. I'm thinking Lambert-Eaton syndrome, botulism, and then disorders associated with aminoglycosides use. Can anyone give me a single aminoglycoside? I know it's pharmacology. What's a good one? Gentamicin, streptomycin. Does some of those sound familiar? Cool. Don't worry. We'll go over it together. All right. So peripheral nervous system, central nervous system, we hammered that home in the last couple of lessons. Does anyone have any questions on that? All right, dermatomes, and you guys have seen that dermatonal map where we have the patient bend over and we can see those dermatomes. They make a lot more sense for us moving all the way back. All right, getting into the structure of the nerve, we have the cell body and then we have the nerve fibers, which consist of the axon. And let me pull up my laser pointer. That would be helpful. So I got my cell body here, which controls everything coming in. I got my dendrites around to the outside, and I got the axon is all this stuff coming down here. When we start dealing about demyelination, axonal injury, dendritic injury, just pay attention to the, hey, the dendrites are the stuff coming in, the axon is everything going out and traveling down. Dendrites, meaning little trees, that's the receiving portion of it. Axon, the thing that propagates the signal down. And it can be pretty long in people. It can be up to 3 feet, especially dealing with a upper motor neuron, goes all the way down and can be up to 3 feet. When we talk about things that are length-dependent neuropathies, 3 feet worth of cell that it can affect, those become important because it becomes more pervasive. We see that in stocking glove distributions where the hands are affected first and it works its way up because of a systemic insult that's affecting more of the nerve over time. Axon, pretty long, typically arises from the hillock, which is right here, the first initial segment. Impulses, action potentials generally arise in the trigger zone, the junctional hillock initial segment. Don't worry about that, that's just background information for this slide here. The thing I want to pay attention to here is the synapse. That's where the two things actually connect, because we see a lot of disease states associated with the synapse. Synapses are physically changed with repeated use, especially with learning. As we start using our muscles more, we do more motor neuron recruitment, we have more of those synapses developed. Has anyone ever heard of the idea of lipid rafts? It's this concept that these receptors within these synapses are actually too close together and it can cause them to not work as well. That's why it can take up to 4 weeks for SSRIs to start working, because those serotonin receptors, they're too functionally close together. They've been unused and atrophied for such a long period of time. We're actually waiting for physiologic chemical changes to happen in the brain. Some of the diseases and disorders from the synapse disruption, many therapeutic additive chemicals have sites of action at the synapse. This is all fantastic. Let me walk you through exactly what's going on. Don't worry about, hey, is that a calcium channel? Hey, is that a sodium channel? Again, we covered most of this during AMP. I'm not going to test you and show you a picture of a synapse and say, is this calcium or sodium? So what's happening when a nerve impulse is coming down the nerve, it hits the synaptic bulb of the presynaptic neuron. That means before the signal is transmitted forward. As that's transmitted forward, it depolarizes and it causes those calcium channels gates to open and flow inward. And that causes an exocytosis, or release of those vesicles of those neurotransmitters. We talked about a couple of neurotransmitters. Does anyone remember GABA? Is that one inhibitory or is that one excitatory? Inhibitory. I think of that one with alcohol use disorder. All right. When releasing the neurotransmitter into the synaptic cleft, that's what causes the action to happen. Those neurotransmitters diffuse across the cleft and they bind to the neurotransmitter receptors on the postsynaptic cleft to cause some sort of action for us. That can be either positive or negative. In the case of an upper motor neuron, is that a positive or negative action? Is that inhibitory or is that causing my nerve to be activated? When I see upper motor neuron symptoms, I'm thinking, hey, that's not inhibiting anymore. I have dinosaur arms. I'm very spastic at that point because I have too much activity of the lower motor neuron. I have the ligand-gated channels allowing ions to flow through the membrane. It's sodium from here on out, changing the voltage gated and causes an action potential to happen on the other side. And then the threshold depolarization of the postsynaptic potential triggers one or more impulses. Basically, vesicles travel across, hit the sodium channel receptors, those open up, and it causes something to happen on the dendrite side of the cell. One of the clinical correlations, lidocaine is kind of one of those weird ones. It's a sodium channel blocker, so it's going to prevent that from, even though things are crossing that synaptic cleft, those channels aren't going to open up again. Where else do we use lidocaine other than local injections? It's an antiarrhythmic of some variety. And how much can what's a reasonable, reliable dose we can give a patient before it's too much, mgs per gig? With and without epi, do you guys remember that one at all? From pharmacology? 4 and 7, don't worry. Just keep that in your brain for later. We're not testing on pharmacology terms. I know that's hard to remember. Okay, so as we're moving down these axons, we want to talk about something called the myelin sheath. You guys probably remember that from AMP1. The myelin sheath is basically like the insulation around an electrical cord, and it allows the electricity to travel more better and faster and longer. If you were to have an electrical cord that was just a bare naked copper cable, that would probably cause a lot of issues. So in the peripheral cells, it's called the Schwann cells. When it's part of the central nervous system, it's the oligodendrocytes. If you need a quick, easy way to remember that, what's an oligarch? That's a king, that's one. So think of your central nervous system, you only have one of that, that's probably an oligodendrocyte. Everything else, peripheral nerves, have a ton of those, Schwann bodies. All right. The nerve conduction velocities are based on the diameter of the nerve. I think of that when I deal with those posterior columns. I call them my HDMI cables of sensation. They have a ton of information because that's that fine touch, so it's going to be a thicker cable going up. It's going to be more myelin traveling. And the degree to which the nerve is myelated is going to speed up or slow that down. When we see demyelination, that means these things are breaking down. I have a lot of diseases, so I want you to pay attention to this term because we're just going to say demyelination a lot. That's going to cause slowed conduction velocities along prolonged latencies. That's a really fancy word to say when I do that EMG, that nerve study. It's going to show things slowing down. The other thing I can see is axonal injuries. That's where, hey, this whole axon is chopped off potentially in one or more nerves traveling down. What that does is cause reduced action potential amplitude. So instead of nerve fibers being slowed down, I see decreased volume of actual signal being transmitted. That's your easy way to differentiate, because we're going to talk about EMGs real fast. I'm going to reference it real quick, and it may slow things down or it may actually cause reduced amplitude. That's going to tell you whether it's axonal injuries that are happening or whether or not it's the myelin sheath that's being affected. That may point you to a correct disease state depending upon. All right, so voltage-gated channels only present at the nodes of Ranvier. What happens is increased speed with transmission with less energy. It's traveling pretty fast because it's jumping along those things. One of the disease states we're going to talk about today, Guillain-Barré syndrome, causes demyelination, causes a breakdown to that. And with that decreased myelin, slows nerve conduction to where we start seeing a lot of dysfunction and a lot of neurologic effects as a result. All right, our synapses, they're neurotransmitters. They can be excitatory, they can be inhibitory. I kind of covered that. Upper motor neurons, think inhibitory. Lower motor neurons, think excitatory. And then when we approach a patient, we got three main goals that we're trying to do through these disease states. The first one, we're trying to localize the lesion. We're trying to figure out, hey, with this cranial nerve, I know it exists between this and this part of the brain. The lesion is somewhere along there based upon these findings. We want to identify the cause. Sometimes we need imaging, sometimes we need to go into family history to determine that, and then we determine proper treatment, probably by going online. Don't remember everything. Things will change. Don't say, oh, I remembered this from IPAP, I'm going to do exactly this. Because even in clinical practice, 1-2 years out, things were rapidly changing. So don't memorize this, just kind of keep this as your generalized approach as we're dealing with some of these neuropathies. A lot of these disease states that we're talking about coming up, it's either going to be something sensory, it's going to be something motor, or a combination of the two. You can't really use that reliably to say, oh, you present with these findings, it's this. You can't just use physical exam. We have to ask a lot of questions around it. And these 7 ones generally dig out those things that are different, that'll point you to one disease versus another. So we do have to identify which systems are involved. Is it the motor system, is it the sensory, or is it the autonomic, which can consist of the sympathetic and the parasympathetic, or we have combinations thereof. A lot of these disease states follow kind of one pattern or the other. Teasing that out and saying, hey, this thing is only sensory, but I have motor symptoms, it's probably not your diagnosis. We got to pay attention to the distribution of weakness. This one just kind of pays a lot of money for myself when I'm doing exams on people. If I have one limb that's affected, it's probably a mononeuropathy. If I have both limbs that are affected, is it likely that they have a mononeuropathy on both sides? Not exactly. I'm more thinking something systemic that's going on that's causing those symptoms to arise. So when I see distal symmetric, I think polyneuropathy, something systemic that causes those issues to happen. When I think a single nerve, you guys are in ortho or are halfway through. So you guys are familiar with like a Friday night palsy or Saturday night palsy. We're familiar with ulnar neuropathies. We feel pretty good dealing with carpal tunnel syndrome. Have some of those things popped up yet? Those are all mononeuropathies of varying types. And we'll go over those together from a neurologic perspective. All right. What is the nature of the sensory involvement? We can't just say, hey, you can't feel things. We have to tease out, hey, is it temperature, burning, stabbing sensation, or is it loss of that fine motor perception? What actually carries our fine motor perceptions for us? What spinal tract? What's that thick HDMI cord going up the back that covers most of it? It's a column, it's posterior. Posterior column? Cool. All right, what about for all those other sensations that are coming from our spinal levels and going up to our thalamus to give ourselves like, hey, a sense of pressure, a sense of pain, and a sense of temperature? It goes from spinal to thalamic. What trackway is that? Spinal thalamic, cool. All right. Is there evidence of upper motor neuron involvement? So what do we see with upper motor neuron involvement? I know I'm on that class way all the time. You guys don't always exactly see me do it. Do you guys know dinosaur arms? You probably heard me saying it, but not actually doing it. So when we think upper motor neuron lesion, I'm thinking some type of spastic paralysis. Upper motor neurons, those cause the neurons to not fire as much. So when I have spastic paralysis, I'm thinking, hey, muscles are actually kind of tensing up and causing my body to position like this. Am I seeing hyper or hyporeflexia? Hyper? Hyper, because I hit it, it's not inventory anymore, it's going to kick out like crazy. All right, what about Babinski's reflex? That's a really good determination of like, is it upper or motor? I'm going to hit it with Babinski's. If Babinski's is positive, is that upper or lower motor neuron? Upper, because that's suppressing our primal reflexes. You guys remember that? Cool. All right, What is Babinski's positive? When is it negative? Positive's filing out, slamming, love it. All right, so what's the temporal evolution? And you guys heard my spiel. If it's acute, it's usually days. If it's subacute, think weeks. If it's chronic, think months. That's a quick, easy way. Different disease states will say, no, chronic only starts at 3. Just kind of keep that straight in your head, and that'll keep you straight for a lot of things. And is there evidence of a hereditary neuropathy? We're going to talk about things that are autosomal dominant, and we're going to talk about things that are autosomal recessive. If I have a mother that's autosomal dominant for something, what's my chances of actually getting it, assuming the dad's wild type normal? It's a 50-50 split, right? Because they can only give 2 genes unless they have 2 of them, then that's just a really bad day. What about for my people that are autosomal recessive? Do those things happen as much? What has to happen to get an autosomal recessive disorder? We need 2 of it, right? So both mom and dad somewhere in the family history need it, or mom needs to be really unlucky, actually have it and have 2 of the recessive genes, but even then you're getting 1 from dad. No, it needs to come from both sides. So pay attention to that. Think autosomal dominant, autosomal recessive. That'll tell you, hey, this is going to be super common if mom has it, or no, this is going to be only if the two families got really unlucky with each other, or are maybe related to each other in ways they don't know. All right. Are there any association with medical conditions? Think cancer, diabetes mellitus. Some infection diseases can cause a lot of issues in people. We're going to talk about Hansen's disease. Do you guys remember which one that is from? We've had infectious disease, right? Kinda. Do you remember, like Hansen's? Do you remember leprosy? Well, yeah, Hansen's disease. Cool. Don't worry. We'll go over that one at length with each other. The more you repeat these things, the more likely they are to stick in your head. And then we'll talk about some medications, over-the-counter drugs that may cause some toxic neuropathies. And then we'll talk about some of the preceding events, toxins, drugs that can cause issues. What's some of the drugs that we're worried about that people are doing on the streets nowadays? Vape pens are the biggest offending one. I think, were you guys able to hear me when I talked about the term gas station sober? You'll hear that in the ER sometimes, wait for your attending to actually use it, but there's a ton of the psychoactive, neuroactive things that you can get over the counter at a gas station. Just because someone says, no, I'm not doing illegal drugs, you never know what they're getting at the local store. Kratom, a lot of times they'll assume things are other things. All right, so it's time to finally get into some of the actual disease states. I think it plays. All right. So let's talk about some of those neuropathies. Mononeuropathies are going to be really familiar with you guys. Polyneuropathies, we'll cover a few of them. Can I diagnose someone with just a polyneuropathy, or do I have to get into the very specific, oh, it's B12, or it's this one or this one? I can actually send someone with, hey, it's a mononeuropathy, and send them off to ortho, and they're going to tease out, oh yeah, it's actually carpal tunnel syndrome. I can use those as valid diagnosis codes. Mononeuropathy multiplex, and this image here I think kind of displays it really well. A mononeuropathy is going to be in one single spot. A polyneuropathy is going to be somewhat symmetrical. It's going to affect probably the further ones first, but it's going to fit a very similar pattern. And then I got this thing called mononeuropathy multiplex. That's that kind of complex one where, hey, I might have it over here one day, it might disappear, I might have it in kind of unequal spots. It doesn't follow that symmetric distribution that I see with polyneuropathies. And then there's a couple of special categories. There's a bunch of inherited ones and immune-mediated ones we're going to talk about. If you have difficulty figuring out which category it is in, just poke your head up, I'll let you know, because I know it's easy to just keep going disease to disease, and you're like, wait, what category are we in? All right, so mononeuropathies, like we talked about, affects a single nerve along the way. You guys are going to recognize a lot of these names. If I have radiculopathy, that's going to cause a dermatomal patterns. Think, hey, my spine's being pinched in one very specific spot. Because that spinal nerve innervates a dermatome, that's going to cause that pattern. If the mononeuropathy happens somewhere in a peripheral nerve, it's going to follow that pattern instead. Because sometimes we have dermatomes that follow things, other times we use the ulnar nerve to describe it. It depends on where the actual pinch point is. If you get really confused with a patient, just ask them where they're having pain. If they're having neck pain and then a neuropathy because of it, it's probably because of a radiculopathy. If they're having pain in their hand and it's because they have pain in their elbow or they bang their funny bone really hard, they probably have a peripheral neuropathy. I'm thinking that ulnar nerve distribution. All right, so some of the most common ones, facial palsy, Bell's palsy, we covered that in some of the initial lessons. Say I got someone showing up to the ER with a facial droop and I'm concerned he has a stroke. I say, hey, look at me like this. If he gives me the rock, is that good or bad? Good, because the rock is a wrestler and there's always bells in the rings, right? And they go ding, ding. The rock don't hear no bell? Or is it, you smell what the rock is cooking? I don't know what he says. All right. Another one for us is going to be that Saturday night palsy. I either call it Saturday night palsy or Friday night palsy. I always get it confused. We got the median nerve. It's going to cause carpal tunnel syndrome. Can anyone show me where the median nerve is? Like, talk me through it. I see a couple of people pointing. We feel pretty good about that one. You're going to use that one a lot. We got the ulnar. What kind of tunnel syndrome is that associated with? We know cubital tunnel? Cool. Just think of when you bang your funny bone, you're going to feel that ulnar nerve every single time. And then that lateral femoral cutaneous nerve causing myalgia paresthetica. I know those are really advanced words. You guys have seen that disease state before, right, with ortho? Have we covered lower extremities yet? Maybe. Have we seen this before? Yes or no, anyone? Yes. Okay, I'll cover it for you guys, don't worry. It's okay. All right, so radial neuropathy. We think backside of the hand, right? Saturday night palsy, because I got this guy sitting in a chair right here, kind of fell asleep, drank too much, pushes on that radial nerve up into the armpit and can cause a lot of issues. A lot of times it tends to come back, but I'm going to see a wrist drop. I'm going to see motor and sensory combine with that. And a lot of times that dorsal first web space strongly localizes to the radial nerve. Just know where that radial nerve distribution is. I may describe it with words, I may describe it with images, just be able to pick that out. I see the wrist drop, the weakness. Are we expecting this to come back in most cases? Depends on the mechanism of injury. Not everyone falls drunk over the back of a chair. You could see someone have surgery, have injury to there. You could see someone have traumatic, like arm dislocated, causing a lot of issues with that. There's a lot of different reasons. Not every single neuropathy is going to be like, oh, you have a Saturday night palsy. That's kind of silly. Look at the underlying mechanism, because depending upon the extent of the injury, that's going to tell you the extent of the recovery. Where's a good place to refer these people to? Physical therapy is a good one. Anytime I deal elbows down, are you guys familiar with occupational therapy? I feel like it was underemphasized when I was in school here. And I just ended up sending a lot more people to OT than I realized, just because I dealt with a lot more elbows down injuries. Here you got to look at the whole body, but you start dealing with actual ADLs and things that bother people, their hands are what they work with the most. I can have a numb foot, that's fine, but my hand goes numb, that's going to be a pain in my butt trying to work for the day. I sent way more people to OT than I thought I'd realize. So just know that occupational therapy, OT, get familiar with those. Think physical therapy, elbows down, this would be a really good option for OT. All right, carpal tunnel syndrome. You guys feel really good about this one? Relatively? Okay, so thumb, index finger, middle finger, carpal tunnel syndrome. Does anyone actually have carpal tunnel syndrome? So the flexor retinaculum, medium nerve coming through, that can cause some paresthesias, that can cause some motor difficulties. One of the things that kind of stuck out to me, because we always talk about, where's our thenar eminence? I'm pointing to it, it's okay. So our thenar eminence is right here. Do we expect to see atrophy here? Long-standing, maybe. What ended up seeing, the thenar eminence sensation is often spared. Even though that's part of that median nerve distribution, if it's not numb there, that's okay because it actually comes from a different part of the median nerve that doesn't go through that plexus. So don't always say, oh, your carpal tunnel syndrome can't be that bad. You don't have any thenar wasting yet. No, send them off, get the nerve conduction study if you're like, hey, I'm really thinking of sending this guy off for a carpal tunnel release. Are you guys familiar with the carpal tunnel release? Did we talk about that in ortho at all? Or like show that as a potential treatment? Yes? Okay. And then you guys, I emphasized it with the sophomores, I'm going to emphasize it with you guys. When I say Tinel's sign, I say Phelan's sign, I say carpal compression test, I expect you guys to be able to describe that in words. I'm not going to give you an exam and say, oh, is it this test, this test, this test? That's freshman. What I'm looking for in these ones is you guys actually able to pick it out if I describe what that maneuver is. So you have to show me that you know how to actually perform the test on a written test. All right, carpal tunnel syndrome, prolonged median sensory latency before motor nerves develop. Again, we see that tingling sensation way ahead of motor issues. OT is the way to go, and surgical decompression like we talked about. All right, ulnar neuropathy. We think of cubital tunnel. If you're questioning whether or not it's the inside of the elbow or outside of the elbow, it is the inside of the elbow. Just go back to that. Think of where you bump your funny bone. You'll find it every single time. Things that we can see is decreased sensation. It's going to perform very similarly to that median nerve. And one of the special tests that I don't think you guys have gotten yet is called Frohman's sign. What you're going to do is you're going to take a sheet of paper with the patient and you say, all right, we're going to play tug of war real quick. This image here shows the patient side. What's happening is he's flexing that thumb at the IP joint because he has a weakness of the adductor pollicis longus, being that thing that abducts your thumb, brings it closer to the hand. When they have that weakness, they rotate it out so they can pinch it more. So think of Frohman's sign. Have you guys been exposed to that one before, or is this your first time hearing it? I see yes and no. Cool. All right, cubital tunnel syndrome, slowing of the nerve conduction study, slowing along the ulnar nerve around the elbow. Activity modifications, again, we're going to OT with these guys. They do actually really good with OT. They put them through a lot of work. They can do nerve glides, they can do steroid injections, they can do ultrasound type stuff. OT has a lot of modalities that can help these people out. When you send them off to OT, send them with a goal. Say, hey, here is the ADL that he can't do anymore. He's an aircraft mechanic and he can't turn this wrench. He wants to turn a wrench again. That way they know exactly what they're trying to do. Because OT is not just dealing with, hey, I got a ton of active duty guys with elbow pain. They're dealing with people that have had strokes and are trying to get back to being able to swallow again. Being able to offer that allows them to say, hey, here's how much I actually need to see this guy. Make sure we put an exact goal of what we're trying to achieve with occupational therapy and physical therapy. All right, myalgia paresthetica, I think I got some okay responses on this. Maybe some of the sophomores may not have seen this yet. This is a really simple one. This is one of the few, I know my peripheral nerves for my upper extremity pretty quick. I don't know them for the rest of my leg. Like sural nerve, I get kind of confused in the real world. The one I do remember every single time is that lateral femoral cutaneous nerve. It pops up in a ton of questions. I actually see it a lot in clinic too. They're just like, hey, I have this phantom like cell phone sign. We have kind of a lot of more obese patients that we see, so we see this nerve getting entrapped a lot. What lateral femoral cutaneous neuropathy is that lateral femoral cutaneous nerve getting entrapped right here along the iliac crest. It's very easy for this to happen. Physical therapy, weight loss work pretty good for this. I don't think there's a surgery necessary to correct this one. I could double check, but the weight loss, lidoderm patches. What's a medication that we like for neuropathic pain? Gabapentin. What about the other one? Pregabalin. Do you guys have an idea of which one you actually want to prescribe yet? It's okay. I started off with gabapentin a lot. And I had a lot of difficulty keeping patients on it because it was super drowsy, sedating. It didn't work for a lot of active duty guys. Occasionally you get the really bad back pain where it buys them enough relief, or people that need help with sleep. And in my mind, I put Lyrica off to the side because I'm like, oh, that's a scheduled drug. They're going to get high on that. I can't prescribe that one. And I prescribed it once and I was like, oh, you did really well with that. And I prescribed it again and I didn't get arrested. And I'm like, okay. So I started doing pregabalin a little bit more and I had a little bit better results. Just pay attention to it. Don't put one way off to the side. Talk with your pain management that's local to the area because you're going to refer people out. That's how I saw it. And I was like, hey, everyone that I'm sending on gabapentin, it doesn't work. They're putting them on pregabalin, Lyrica, and they're doing a lot better. I was scared of the drug because it was controlled. In reality, it's uncontrolled. It does the exact same thing, but it doesn't have that drowsy effect that prevents it from being addictive behavior potentially. Am I going to get a person addicted to being on pregabalin? Probably not. It's not the same level of opioids. Don't group all controlled medications in together. I honestly got a lot better results from putting people on pregabalin. Start with your gabapentin, do what your normal flow is, and pay attention to your prior auths. Go ahead. Oh, thank you. I'll read it. I'm able to do this. Sir, for the ortho concepts, could you explain a little bit more for us sophomores? Okay, so go over everything I did. Let me see what I can tease out that would make that easier for you guys to understand. It's okay. This will be real quick. For the sophomore class, because I know you guys are like, oh my gosh, I've never been exposed to these. The juniors, you've seen it. You're like, okay, I got it. We're moving on. We know our peripheral nerves for the sophomores. Is that correct? Do we know where our median nerve is, ulnar nerve? If anyone wants to pipe up in the chat if they're familiar with where those dermatome. Yes, okay, we're good with those ones. When we pay attention to where those nerves actually travel and where they can get compressed, the two places they can get compressed, I think of the wrist as the most common spot, and then I think of the elbow when I'm dealing with that cubital tunnel syndrome. These are my two pinch points. If I know my wrist is going to cause that pain going down that median nerve distribution, those first couple of fingers, great. If I know cubital tunnel syndrome, that's my funny bone that can get trapped, not just traumatically. That causes those bottom two fingers to get irritated. You understand cubital tunnel syndrome. That's kind of the quick, easy review. And I think that other than that radial nerve covers the back of the hand. And what we see with this Saturday night palsy, guy falls asleep on a chair, pushes on the nerve doesn't like to conduct anymore. Predominantly sensory, can also cause some motor issues, and the recovery is going to be dependent upon how bad the nerve was actually injured. Is that an okay kind of quick review, just once over one more time without driving the juniors crazy? Is that okay with the sophomores? Tinel sign and fail. Oh, so you guys don't know those. All right, so for Tinel sign, does anyone in the junior class can describe for me what Tinel sign is? Tapping Tinel. So everyone's tapping on their wrist right now. What I do is I flip the wrist over and I tap right where that flexor retinaculum is. And what that will cause is my median nerve to actually get irritated. And I just caused it to myself. You'll actually cause a sensation of pain where that is, a tingling sensation, and you ask the patient to do that. Can anyone show me Phelan's sign? So think about folding our wrists over. I know you guys don't have video. That makes it kind of hard to do because we're just doing it.
An upside down prayer.
If you guys want to, the next time we have a block, I'll go over it because I'll be in the sophomore class again. It'll be a lot more easier to show these and have you guys do them. So they are remote on. Yeah, no, they aren't. They're not there. There might be one or two of them. But I'll go over that one. Can anyone show me the carpal compression test? We're pushing on it, right? And we're seeing if it recreates any of those symptoms. All of these, we're just trying to push on the nerve and manipulate it as it's going through there. But next time I'm in the sophomore classroom, I'll show up, we'll call it 5-10 minutes early, and I'll go through all the tests with you individually so you can practice on each other. Again, I'm not going to go crazy into testing these because you guys haven't had ortho yet, so I'll make sure that isn't heavily emphasized in the test. Are you guys good with that? Cool. All right, polyneuropathies. All right, next I want to cover some polyneuropathies. Polyneuropathies, think of, hey, this is affecting both upper extremities, both lower extremities, starts far, works its way near. Here we have some length-dependent polyneuropathies, meaning the further it is, the more the nerves are affected systemically, the more sooner my symptoms develop. So it may start in the feet, think a stocking distribution, that's what we're talking about, and then it travels up the hands. That's a glove distribution. We see that happen in a lot of disease states. So think of, hey, if it's happening on both sides, it's happening symmetrically. Think of something that could potentially happen that would cause a systemic issue with nerves. B12 deficiency is one of the big ones that we see happen with this. So what happens, we know pernicious anemia, that's where we lose that intrinsic factor. You guys had GI. What semester was that in? This semester. So sophomores, don't freak out. B12, so B12 is a vitamin, and B12 is used in a lot of different things. Sometimes we can lose our ability to absorb B12 from our diet because of something called intrinsic factor. I'm not going to base a question on how you absorb B12. It's going to be strictly neurological related. So some of the neurologic findings may occur with or without significant anemia. You guys covered that in hematology, correct? The different causes of macrocytic and microcytic anemias? We haven't taken heme yet? Great, don't worry about it. So this can cause anemia. We're familiar with the term anemia. All right, cool. We got a common ground together. This is great. So anemias can cause two different things. They can cause the red blood cells to be enlarged, or they can cause the red blood cells to be small. That's that first crowbar separation pathway we go down when we say, hey, this guy has anemia. If I have a microcytic anemia, is that small red blood cells or large blood cells? Small, microscope. If it's macro, that's big. So this causes a macrocytic anemia, meaning your red blood cells, they're not quite forming right, and they just kind of get abnormally large because they're trying to work, but they don't work well. What we see when we are suspecting someone has a polyneuropathy due to B12, we can have macroovulocytes and hypersegmented neutrophils, and I looked what that is. It's a red blood cell that kind of looks ovally and large, and then I got a neutrophil that has way too many little lobes inside of it. And you guys all had microbiology, correct? What does a neutrophil do? Is that viruses or bacteria? One of the lab tests that we can do in this one, we can get a methylmalonic acid or a homocysteine. Don't worry, you guys probably didn't get that in Clin Lab. This is kind of one of the only spots these two pop up. You don't have to say, oh, I'm going to order this every single time. This is a great test pearl that Pants likes to do. I see a panicked look, it's okay. These are typically elevated in B12 deficiencies. Just keep that in your mind. I'm not going to throw a crazy test question on labs that you guys haven't covered in a billion years. But keep that in mind when you guys move on to the pants, because they're going to say, hey, what's a lab value I can check? You see homocysteine, you're like, I've never heard of that before except this one class Major McMahon was teaching B12 deficiency. You say, it's probably B12 deficiency. That's the level of recognition needed with some of these. On the test, could you describe a special test or name it if the provider taps on the wrist with eliciting a tingle sensation as opposed to positive Tinel sign? Yeah, I'm not going to use the name of a positive sign. I'm going to describe what the patient is actually doing. I know for the sophomores, I'm going to make sure I take an extra 10 minutes before so you guys know exactly what we're talking about. I'll make sure it's within the things that you've been taught. Sorry, answering a chat. Thanks, cool. All right, B12 deficiency. What do we do if someone's deficient in B12? We replace it with B12. Good. Can we do oral dose in someone that's missing? We haven't had a GI yet. No, we're not going to pay attention to that. So the biggest thing to pay attention to, if I have someone develop a polyneuropathy, I'm going to order some labs, maybe cysteine, maybe look at the blood, at least a CBC. If I see, hey, this person's anemic and their red blood cells are large, classically by that point you're going to know that's a B12 deficiency or potentially one of them. You're going to know they have neurologic symptoms. You're going to say, oh, cool. In addition to your anemia, I know that weird neurologic symptoms you have affecting your hands and feet. This is probably a B12 deficiency. All right, diabetic neuropathy. This should be back into the wheelhouse. I know B12 kind of threw you guys for a loop real quick. This is the most common complication of diabetes. Diabetes mellitus is one of the most common causes of peripheral neuropathy. These are very like, hey, pay attention to this. You're going to get a billion test questions on this in the future when you're dealing with PANCs. Distal symmetric polyneuropathy, length-dependent dying back neuropathy. When we said that length-dependent, the further it is, the more likely it is to be affected. Starts at the feet, works its way up, starts working into the hands. Ankle reflexes are often reduced or early absent, and we can also see ulcerations and Charcot arthropathy. So, has anyone seen diabetic feet before? They kind of have a lot of ulcers. They kind of got that weird like flat foot, like plodding almost going on. That's why you see those diabetic sneakers a lot designed to protect the feet. What's happening is all those protective mechanisms and muscle tone are going out the window because they have diabetic neuropathy. And that can actually cause this flat bottomed foot to appear because all those intrinsic muscles are disappearing and causes a lot of issues. Especially you throw weight gain on top of that, you can end up with the foot kind of falling apart. All right, stocking glove pattern, you're gonna see that pop up on tests a bunch of times. That's always them trying to clue you into a diabetic neuropathy. Other things that can cause stocking glove distribution? Yeah, B12, I just gave that one to you. So don't let it sink you in every single time that, oh, this patient's diabetic. There are other reasons that can cause it, but this is going to be your most common one. Some of the things that we see on physical exam, bilateral symmetric associated with dull perception of vibration pain. What we do is, has anyone ever seen a 10-gram monofilament? Anyone done foot checks before for diabetes? I see a nod on the face. Imagine a toothbrush, but it only has one single bristle on it. And what that bristle is like a little bit of fishing line. It breaks at about 10 grams worth of pressure. And you sit there and you hit the foot because that's a very like standardized way to measure a foot. But that's how you'll determine, hey, this guy's sensation is getting better or worse. You don't typically do a lot of diabetic foot exams. That may be something you have to get trained in depending upon what your patient population is. But just know that monofilament is a test that we use in diabetic neuropathies to determine, map out progression and see how bad things are going. You can do a diagnosis, a nerve conduction study that can show slowing, nerve biopsy if you're really concerned it might be something else, axonals or degeneration. Do I get a nerve biopsy on every single diabetic neuropathy patient I see? No. It's going to be reserved for cases where I'm like, hey, I think it might be something else. I want to make sure it's not this. I want to get a biopsy actually confirmed. That's a lot of pain to put people through. We can see some autonomic neuropathy occur with this as well. Autonomic meaning peripheral nervous system, meaning our sympathetic and parasympathetic systems, excuse me. We can see vasomotor disturbances in the limb leading to orthostatic hypotension. What happens when people have orthostatic hypotension? They stand up, they kind of pass out, they may feel a little bit woozy. We have a whole lesson on dizziness coming up, get excited for it. We may see some sweating disturbances, cardiovascular, they see exercise intolerance and dizziness. When you're pushing your diabetic patients to work out more, just know, hey, this might be contributing to their exercise intolerance or their inability to do that. Hypoglycemia unawareness. The first time you're hypoglycemic, it affects you pretty badly, correct? Have we covered diabetes in any other course yet? We just know the term from layman's? Cool. I'll give you guys a little bit of background. So when your blood sugar goes low, we start to feel faint, we may pass out, we may have some altered mental status type stuff. The first time it happens, you have a pretty strong response. Every time after that, your body responds less and less. My severe diabetics, they can become hypoglycemic, and they might not even know it until it's a dangerous level and it affects them like that. So just pay attention to that. Intolerance becomes, unawareness becomes a serious thing because your blood sugar might be panned out and it might be an emergency and we're not paying attention. All right, GI issues, gastric atony, meaning gastroparesis. Are you guys familiar with that term? Do we know what that means? We're all about the GLP-1s. Gastroparesis means we're not moving things through our stomach anymore, causes a lot of stomach pain. And then GU, we can see bladder dysfunction. And erectile dysfunction is honestly one of the first things. Erections are like this weird indicator of health that involves your parasympathetic nervous system, your sympathetic nervous system. It involves vascular, it involves psychology. Once that stops working, say, hey, these are all the different things that can cause this weird indicator of health to disappear in people. Take it seriously. Don't just say, hey, he's a 40-year-old that has ED. Every 40-year-old gets ED. No, pay attention and look at the underlying reasons. Make sure I'm not missing anything. Okay, glycemic control is one of the first things that we want to do. They offer a lot of test questions because there's a ton of diabetes and we see a lot of diabetes complications. We also like to pay attention to what we're supposed to do with that. So a lot of times test questions will be like, hey, do I want to give them something for the pain or do I want to do this? Get the glycemic index under control. Put them on metformin, put them on GLP-1s, put them on the appropriate management for diabetes, and then start working through your symptomatic treatment. Duloxetine is a really good one because that's my one SSRI that has an indication for pain control. If they're on a different SSRI, will that still help? Or is it only because it has an FDA indication? It can work. A lot of them can work both ways. I reach for duloxetine first in those painful indications because it's nice, but a lot of those other SSRIs, pain has this very big psychological component to it, and we forget that a lot of times. Reaching for those SSRIs, even if it's not duloxetine or if they're on Prozac already, don't switch them over to duloxetine saying, oh, this is going to work way better because the FDA says so. No, you still get that psychological effect of trying to offload some of that psychological burden of pain. And then I got pregabalin and gabapentin, and you guys heard my spiel. Start with gabapentin, work up to pregabalin until you feel comfortable and figure out your differences between the two. Talk to your pain management guys because they'll say, hey, this guy's a good candidate for XYZ. All right, we can also get some neuropathies with HIV. And it's not the HIV virus that's directly causing us to have neuropathies. It's all those weird secondary infections that we see when we don't have an immune system anymore. Number one, this is very high yield, especially for HIV as an infectious disease, as well as for our own neurology needs, is cytomegalovirus. That first thing that we see cause a lot of systemic issues in people. And this can cause a lot of different ones. It can cause that distal symmetric polyneuropathy. It can cause that inflammatory demyelinating polyneuropathy. Don't worry about trying to differentiate these two ones. Just know it can cause a lot of different issues. I think we cover a couple of these in different ways, but don't worry about trying to memorize these type with an HIV infection. Just know that an HIV infection can cause any number of viruses or bacteria to cause your body to respond in a weird way because you don't have an immune system. Just for everyone in the chat, don't memorize the types of HIV infection neuropathies. All right. We covered mononeuropathies. We feel pretty good. It's kind of ortho. We'll spend some time with the sophomores so they feel a little bit more comfortable with that. We covered some of the polyneuropathies, and there's a ton more. I covered some of the high yield ones. I can't do completely exhaustive. Alcohol was the other weird one that kind of had a lot of polyneuropathy associated with it, but I limited it to just some kind of like flagship cases. The next one is this thing called mononeuropathy multiplex. So that's that, hey, here hurts this day, and then it stopped, and now it hurts down here, and then it stopped, and now it's kind of here. It's a weird pattern over time and space. Painful asymmetric involvement, non-contiguous peripheral nerves is classic. When I see this pattern, I think vasculitic reasons. Diabetes can cause either polyneuropathy or mononeuropathy. Infection and systemic inflammatory diseases. Think of something that can be really obnoxious in one specific spot, but still kind of systemic. Vasculitis is inflammation of the vascular system can be at the top of the list. So when I hear someone that has an asymmetric, multifocal, painful, I think mononeuropathy multiplex. All right, let's cover a couple of diseases real quick. Has anyone ever had Lyme disease? Just me? Sucked, it wasn't fun. All right, so what is the causative agent of Lyme's disease? Good job, guys. All right, and the culprit is a bite from a tick. Do we have this kind of tick around here? Potentially, I think so. Think northeast. A lot of times when we deal with these like weird tick-borne diseases or arthropod diseases, just pay attention to what's in your local area. I got it when I was in Rhode Island, and I think that's where it started. When I was in Europe for a little bit, we had tick-borne encephalitis was a big deal, and it's not a thing over here as much. What's kind of some tick-borne diseases we have that are local to the area? Rocky Mountain spotted fever, that's a good one. I think it kind of comes down. What about the Lone Star tick? You guys familiar with that one? What does that one cause? That's just kind of layman's knowledge. It can actually cause you to become allergic to a lot of foods. Alpha-gal syndrome, because you get exposed to this antibody that's in its not normally in your blood. It can cause a lot of intolerance of foods and meats. We'll take a break in about 5 seconds. I'm just going to finish this slide for you guys. So with Lyme's disease, have you guys had infectious disease? We're in it right now. Have we covered Lyme disease yet, or is that kind of popping up? Yeah, okay, cool. Sophomores have not had this, and that's okay. We're just going to focus on the neurology portion of it. So when we get Lyme's disease, one of the things that can happen is we can get a facial palsy, meaning facial nerves having a palsy. A lot of the stuff we've talked about, stroke and Bell's palsy, affects one side of the face. Think systemic diseases, both sides of the face. My guy's face right here, he has a palsy on both sides. You say, hey, raise your eyebrows, and neither side goes up. We're thinking bilateral palsy. EDX, that's referring to electronic diagnosis. That means doing a nerve conduction study. That means the axons are having problems. That means it's that low voltage that we're seeing. And then the biopsy, if you're really confused what you're dealing with, more often than not, you're going to find the Lyme's disease first, and then you're going to have the neurologic symptoms secondary. And then how do we treat Lyme's disease? And this goes for the sophomores too. Just pay attention to this portion. We like to treat it with doxycycline. If I were to write a test question about this, I may clue into this bullseye rash, or I might show this. I wouldn't just show the neuropathy and say, what causes bilateral facial neuropathy? That could be anything. I have to hem it in to say, hey, this is pointing to this type disease state. What could this be? All right, shingles. Shingles does not care. Does anyone remember those commercials? This will be the last slide, then we'll take a break. I appreciate you guys for pushing. All right, so how would we describe this pattern here? Dermatonal, because it likes to hang out in that nerve and it doesn't care. It's Easter. Has anyone actually seen these commercials? It's like your grandma doing something fun and it says Singles doesn't care because it's just going to get her out of nowhere. So the way this virus works, it lays dormant inside the nerves and just hangs out for a really long time. And then what can happen is it can just periodically get reactivated. And it's in most of us. I have it in my armpit from wrestling days. What can eventually happen is that nerve gets reactivated, or that virus gets reactivated, and it causes this really nasty rash. What happens before that rash shows up? We get a prodrome. What is a prodrome? It could be local to that. Sometimes prodrome can mean like within a migraine headache, I got like weird neurologic symptoms. Prodromes can be kind of systemic where I get like fever, aches, chills. Specifically when we're dealing with herpes, we're thinking, hey, it's kind of itchy, tingly right on this exact spot. And I've seen a ton of patients where they're like, hey, it's exactly right here. And I'm like, I got you. Let me give you the purple pill called Valtrex real quick. And then you see him back in a few days and it kind of flares up. Severe pain, paresthesias along the dermatome. Is this causing motor dysfunction? Probably not. It's more sensory at this point, followed by pain, paresthesias may precede the vesicular eruptions. And we'd be able to identify this lesion if we saw a picture of it, correct? It's pretty much that kind of papular. Sometimes it looks like little vesicles. There's nothing really in it. Vaccine is available for it. You guys want to take a 10-minute break? I think now's a good spot. I appreciate you guys. What's that? More better, less worse? Always good. Yeah, I don't want to show the taskbar. All right, you guys ready to get back on it? All right, sweet. So dealing with herpes varicella, one of the places that we can get affected, we know our dermatomes of our face, correct? V1, 2, 3, which one's V1? Top, because it's the least number, it's the lightest. All right, what can happen if we start affecting the V1 dermatome? If we see vesicles on top of our nose, we're worried about something called herpes zoster ophthalmicus. That can cause a threat to vision. That's called Hutchinson's sign when this appears. Let me grab my laser pointer again. That's helpful for the remotes. Boop. When we start developing that dermatonal pattern on the face, it's very concerning what involves the nose. Other things that we can see, it can involve the soft palate and the tongue as well, so watch out for those ones. Other thing that we can develop is something called Ramsay-Hunt syndrome. That's going to be sensorineural hearing loss, ipsilateral facial droop, and mouth lesions. And just, oops, let me go back a little bit. So the two things I'm worried about with herpes zoster when it's affecting our dermatomes on our face, Hutchinson's sign with the nose, Ramsay-Hunt syndrome with the ear, and I have a picture of the ear later on that'll show you what some of those lesions look like when they start affecting the ear. But think, hey, if this is going to affect my optic nerve, which it can, or if this is going to affect my vestibular cochlear, I want to put them on a much different treatment, preferably antiviral therapy. All right. I got something called leprosy, aka Hansen's disease. The juniors have had this, the sophomores have not. Don't sweat it out, it's very easy to recognize. The biggest thing, is someone going to present with a neuropathy and, oh, by the way, I have leprosy? No, it's going to be the opposite way around. They're going to present with, hey, I have leprosy. Oh, by the way, I have a neuropathy because of it. As long as we can recognize that, fantastic. So what would someone with Hansen's disease actually look like? We see osteomyelitis recurring. That's going to cause these lesions where things on the fingers just kind of randomly start falling off. They get kind of repeat infections chronically over a long period of time. Does anyone remember what a leper colony is? I don't think anyone was old enough to be in a leper colony. They're kind of like in movies. Have you? There is one? The remnants of it, yeah. So these are important things. This is a big part of history. More commonly than not, we're not going to see this in America. We're going to see this in Southeast Asia, Africa, and South America. And this is the most common cause of peripheral neuropathy in those areas. The good news is now that we can treat it, and the way that we like to treat it was with rifampin. Don't worry about the dosages, the different, hey, if it's tuberculosis versus the leopardness, don't worry about trying to tease those out. You guys either got that infectious disease already, or for the sophomores, you're going to get that in a different class. The big thing I want you to recognize is, hey, if I got someone presenting from this kind of area and they have this kind of thing, and I suspect they have a neuropathy, what's the most common one? Oh, by the way, their hands look like this. Hey, it's probably Hansen's disease, aka leprosy. Think someone in a leper colony. When you saw people in the leper colony, they covered themselves up, right? With like the black robe. Has anyone actually seen a leper colony? They don't exist, but like in movies or like in ancient history. I'll put a picture of it, what it looks like in the next slide deck as like an additional add-on, just so you can like have that mnemonic. But these people covered themselves up because we see a lot of deformities because of that. People's noses falling off. It looks pretty nasty when it actually happens. All right, when we have a neuropathy, it can take a long time for it to recover. Nerves can regrow to some extent. It can take up to, a millimeter for 2 to 3 millimeters per year. It's very slow when it actually happens. Depending upon how bad it is and how much is affected, that's going to tell you how long these things take to get back. My most common place where I see a neuropathy and it kind of resolves spontaneously, people coming out of ranger school, because they've been going really hard for a really long time. They have a lot of back pain. They probably had trench foot from exposure. They have just both their feet have this weird tingling sensation. Is it going to fit one of these clean diagnoses? No, I'm just going to call it, hey, it's got this weird kind of distal polyneuropathy secondary to it. That's why I like that diagnosis. It doesn't need to be, oh, it fits this exact thing every single time. You got trench foot. No, it's not a clean diagnosis like that. So a lot of my people coming out of ranger school, how long is ranger school? 62? It's pretty short, right? It's pretty long, depending on what you're looking at. But repetitive chronic pain like that, those guys tend to resolve within about 3 to 6 months. They start feeling more normal back to themselves once that insult to those peripheral nerves stops recurring as frequently as it does. I actually ended up doing like a lot of post-ranger physicals for my guys, because them finishing up ranger schools, they always come back and they're like, yo, my feet don't work no good no more. And I'm like, it's all right, come on in. I'm used to seeing this. I got a predictable recovery pattern for this polyneuropathy you have. It's going to take about 2 to 3 months for things to get back to normal. Let's get you in with PT a little bit. Let's cover you with a profile a little bit so you can get back to feeling normal. Good job on getting your ranger tab. Or good luck next time. If it's related to demyelination, the patient may recover quickly if the axon is intact. That's important to pay attention to. Think of like, okay, if that surrounding insulation is gone, but it kind of comes back and recovers, that's going to be a lot easier recovery because the groundwork's already laid. The main nerve is still there. If that main nerve gets severed, it's going to take a lot longer, or it may not come back depending upon the degree of injury. All right, let's talk about a couple of inherited neuropathies now. Like I mentioned before, we're going to pay attention to whether or not these are autosomal dominant or autosomal negative. What does autosomal mean? It's not a sex chromosome related one. Most of these are autosomal, so we'll just pay attention to whether or not they're dominant or recessive. Now, for us dealing with Charcot-Marie-Tooth's disease, this was kind of a weird disease that I've never really seen a patient with before. I remember the slide for it. It was the exact same one it was now when I went through. And I was like, I don't think I could like pick out a person with Charcot-Marie-Tooth disease if I saw one in the wild. They'd have to tell me because they've known they'd had it. Is something with an autosomal dominant disease, if mom has it, if dad has it, there's a pretty good chance you're going to end up having it 50-50 chance. They're going to know family history, or you're going to have to elicit them from them and say, hey, do we have any family history of neuropathies? They say, oh yeah, my whole family has Charcot-Marie-Tooth disease, and I do too. Very typically, we see this high arch with people, and we see some distal muscle wasting. Can see hammer toes. Foot drop is a really important thing here. And then we see distal, we see the ankle reflexes are absent, distal weakness. The biggest thing is we can start to see some physical changes because this is a congenital thing. They've had this their whole lives. Who's seen pictures of kids with cerebral palsy? And they kind of have a foot that's pointing a strange direction. They may have some limb length discrepancies. They look a little bit deformed despite having a neuromuscular issue. When we have things that are throughout our congenital period, when we're actually growing and we have spastic responses to that, that can cause some actual physical deformities over a much longer period of time. If you see someone that has physical deformities and has some type of neuropathy, think congenital. All right, so with Charcot-Marie-Tooth disease, it can either be type 1 or type 2. Don't worry about differentiating that. The biggest thing is type 1 is going to be the most common. We see demyelination on the electrodiagnostic as opposed to axonal. Demyelination, again, slows down the conduction. Axonal studies, again, lowers the amplitude. The biggest thing to take away with Charcot-Marie-Tooth disease, it's no one single disease. It's kind of a grouping of a lot of different issues that we see some congenital malformations. No real treatment for these things. A lot of times they end up with the ankle orthotics because they end up with that foot drop. And we have a lot of sensory issues. It can make it kind of difficult walking around in various locations. I left a video because this was one that I had like difficulty actually envisioning what a patient with Charcot-Marie-Tooth disease looks like. I don't think the sophomores are going to be able to receive the sound. I'll make sure you guys have the link to the video. It's a real short, quick, and easy. I'll see if I can hit play on my end. So I'll kind of describe visually what's happening. Basically, she says, and she has normal mentation. Originally, I was like, is this a cerebral palsy? Is there like varying degrees of mental disability? No, she's perfectly normal head up. Bottom down, you can see she's having a little bit of difficulty walking. She says, you know you have CMT when you have difficulty walking downstairs. She has that distal muscle weakness, and she's unable to sense how far things are down. And one of the things that CMT is very specific for is you actually have difficulty walking on grass because she's getting a lot of weird sensations while trying to walk on that, as well as having a foot drop. So you see her kind of developing this very high stepping gait. If you notice her hands, they have like a little bit of deformity to it. The knuckles are kind of enlarged. They almost kind of look slightly spastic. If we have a lot of muscle spasms, some deformities, is that an upper motor neuron or a lower motor neuron? A little bit of each, upper, cool. When we deal with peripheral neuropathies, don't get sunk into those too much because now we're outside of the upper and lower motor neurons. It almost kind of exists outside of that. But good identification of the different systems. Is it helpful to see a patient with this disease sometimes? This was the one time I was like, let me look up the video. And she says, here's a video of my life. She kind of describes it, and it helps a little bit to see someone with it. And you're like, okay, I could recognize those symptoms because I've actually seen someone with it now. All right, I got a very weird, rare disease here. It's called hereditary sensory and autonomic neuropathy, Hassan type 1, Hassan type 2. This is, again, an autosomal dominant. So think, hey, do you have a family history of weird ulcerative lesions and neuropathies? Yeah, 100%. Cool. That's where it's going to pop up. The family history is key to uncovering this one. We can see some distal sensory loss, deep dermal ulcerations, and I'll show you what that looks like. And again, we see this recurrent osteomyelitis. What does that sound like a little bit? The disease we just covered where they go to leper colonies. leprosy, Hansen's disease. So how do we kind of differentiate out the two? Don't you worry, I got a chart for you guys. Don't worry about memorizing everything in the chart. I was just like, hey, both of these kind of present with osteomyelitis. I'm going to expect to see some deformities. I'm going to expect to see some skin changes, just so you understand what some of these ulcerative dermatologic things look like. I can see some gross hand and foot deformities secondary to that osteomyelitis. Hansen's disease is a genetic thing Hassan is a genetic disorder versus Hansen's disease, leprosy, we know that's infectious. So I'm not going to have a family history of leprosy potentially. The pattern, okay, more symmetrical for Hassan versus focal for Hansen's disease. The skin findings are different. So with the hereditary one, Hansen's disease, I'm going to expect to see ulcers secondary to sensory trauma loss versus Hansen's disease. I'm going to see those hypopigmented erythematous lesions. Don't worry, I'm not going to expect you to diagnose Hansen's disease. I'm going to present them in a different way that's a neurologic focus. Family history is going to uncover genetic disorders versus exposure and travel history is going to expose things that I suspect are infectious in nature. And then can we treat leprosy? All day, every day. What can we treat it with? Rifampin. What about Hassan? That's a genetic disorder. Can we treat genetic disorders? Symptomatically, a lot of times, gene therapy is still far off in many cases for us. I got two more genetic conditions. This one's a little bit of a strange one as well, kind of rare. This one's autosomal dominant. I know it's not on the slide. I had to look it up before. Just remember this one's dominant. I got familial amyloid polyneuropathy. Does anyone know what an amyloid is? Amyloid plaques, it kind of pops up in a couple of different diseases sometimes. It's actually just a collection of sticky proteins that are malformed. You have some sort of mutation in your genes that cause transthyretin to not quite work right. Don't worry about what that normally does, kind of works with the thyroid for T4, but it causes a misfolded protein. That kind of sounds like mad cow disease a little bit when you talk about it. But depending upon where these byproducts build up, they can cause issues. These ones cause some amyloid plaques. And specifically, it can cause 4 different things. I got a heart down here because it can cause cardiomyopathies for us. I got painful length-dependent neuropathy. So that causes issues where first? When it's length-dependent. Feet and hands, think stocking and glove distribution on those ones. And the last one where it can cause issues is GI disturbances. So I think heart, hands, stomach, feet. That's going to lead me to my diagnosis of familial amyloid polyneuropathy. And again, this one is dominant, so if you have a family history of it, I think it's going to pop up again. If I were to ask you a question on this, I'd be more pending on like, hey, what's the thing? I wouldn't expect you to diagnose this related to anything else because you're going to ask family history. They say, hey, I have a family history of familial amyloid polyneuropathy. Oh, there's your diagnosis. I might ask, hey, which one of these things is related to that and throw in a cardiomyopathy as well as a bunch of other ones because that's something we need to address. That's the level of detail I'd like to see in these things. That's why I've kind of highlighted some of these ones that differentiate them out. So as you're studying this, you're trying to remember for the pants later on, we can pick up on these things later. All right, Refsum's disease. This disease, I'll start with down here where you see 10-year delay in diagnosis. This disease is very hard to ID because it has so many weird intermittent symptoms. I'm never going to expect you to pick it out of a needle in a haystack. If someone can't diagnose this, average age from onset of symptoms to diagnosis is 11 years. Do I expect you guys to answer it in under 60 seconds in a multiple choice question? No, that's crazy talk. So, just kind of pay attention to this. The reason why we still have to go over it, if we don't teach it at all and never cover it, it's going to die in silence. No one's ever going to be ever diagnosed with it again if we don't teach the next generation of providers exactly what it is. So this is a recessive disorder, meaning family history kind of has to line up perfectly, star-crossed lovers, if you will. And what we're seeing is this thing called photanic acid metabolism, photanic acid accumulation. And you're like, but sir, what is photanic acid? Oh, there you go. It's fish, meat, cheese, various other kind of long-chain fatty acids. It's a byproduct of the breakdown. Have you guys covered phenylketonuria yet, PKU? When did we cover that? That was a lot of head nods for that one, geez. Freshman? What do we know about that one? What do we remember, I guess? I don't remember a lot either. We know a lot of foods have PKU in it, and we say, hey, phenylketonuria, avoid this. We test for it like when they're babies, right, usually? If we have a buildup of this metabolite, it can cause a lot of different weird issues in people, correct? This is kind of a very similar thing, just kind of a very different one. It's so much more rare that PKU is like, does anyone have a snack with a wrapper on it right now? Who's the snack man? Look at the back of it. See if it says PKU, may contain PKUs. A lot of times individual foods will be on it. But Refsum's disease is so rare that very rarely do we see it identified. It's not tested early on. And again, it takes a long time to diagnose this. But for Refsum's disease, just remember, hey, a lot of weird things, photanic acid buildup. I'm probably not going to ask a question, but I want you guys to at least be able to identify it later on if you're like, hey, should I test for photanic acid in this person? This picture here of the skin, originally I saw this slide and this picture was here when I was a junior going through it. It does not cause this stereotypical rash. They were just trying to show itchy, scaly skin. Not all of these people are walking around like lizard men and not being diagnosed for 11 years. Me doing my homework for you guys. All right. Those last couple of things we went over are kind of very rare diseases. This next one coming up, you're going to see it in clinic. You're going to see it on my test multiple times. You're going to see it on the pants multiple times. It's called Guillain-Barré syndrome. Does anyone have anyone that has been affected by it or a family member that has had Guillain-Barré syndrome? I sound like one of those weird commercials. Dude, was it anything that you can talk about?
He got COVID and then shortly after that he got Guillain-Barré.
Yeah.
He was in the hospital for months.
Yep. Okay, so I'll talk you guys through what it is. It's very common. I've had a couple of patients like have it and recover from it or have a history of it. And then I think I caught one in the wild once. So it's the most common variant of this thing called acute inflammatory demyelinating polyradiculopathy. That's a mouthful, just remember AIDP. The reason why we have to remember AIDP is there's a variant called CIDP, which is different than Guillain-Barré. We'll get to it in a second, just treat this as the acute version of it. So most commonly, we're going to see it following up some sort of respiratory like COVID or some type of GI. And the biggest thing, every single pants, you're going to get a question about Campylobacter. It has a very strong association with Campylobacter. What's happening is our immune system kind of goes out of whack and says, oh crap, I don't like my Schwann cells anymore. And it causes demyelination, it causes breakdown of this. Likely autoimmune, we don't know exactly what, we can't put into and say, hey, this is exactly it, but that immune response to non-self antigens causes some problems. A lot of times it's something on a virus that looks just close enough to what's on our Schwann cells that your body says, I can't tell the difference, and it causes it to react as my layman's way of understanding autoimmune disorders. So, signs and symptoms. Pay attention to this, please, I beg you. Usually in the legs and ascends, paralysis is maximal by about 2 weeks, and by 1 month, 9% of people are reaching the maximum amount of symptoms. And it's rapidly evolving over hours to days. This isn't something that chronically happens over weeks to months. It's acute. Sensory symptoms may occur, but this is predominantly a motor issue, as relatively mild compared to the weakness. Deep tendon reflexes are going to be completely gone. And my one patient that I saw that had this, I did my exam, I'm like, I think this guy has Guillain-Barré. And then I looked and I was like, maybe I should test reflexes to be sure. And I went and there was absolutely nothing there. Can anyone tell me where S1 reflex is? Where is it? Achilles tendon? Are you guys able to see me when I do things in the other room? Kinda. You see me when I kick my foot up for S1? Okay. Easiest way to remember your S1 tendon, I have a guy in the sophomore class that's an S1 rep and he cringes at this. What happens when you go to S1 on a Thursday afternoon and IPSA's down? They kick their feet up on the desk and they say, there's nothing we can do for you. And that's their, oh geez, it's always a stretch. That's their Achilles tendon up on the desk. You'll never forget S1. But his S1 was just completely gone. It couldn't hit it. And that's the easiest one to get always. So may progress to muscles of respiration and swallowing. So your friend, was it father, was it someone, distant relative, he ended up hospitalized because respiratory failure is a very high potential. My patient that I had dealt with this ended up inpatient for a very long period of time because he needed help with his respirations. So it's a peripheral nervous system. An extensor Babinski response suggests an alternative central diagnosis, upper versus lower motor neuron syndrome. Does anyone know what that means? So when we're dealing with Guillain-Barré syndrome, we're dealing with peripheral nerves. We're dealing with stuff that's not inside that upper and lower motor neuron anymore. What causes me to have a positive Babinski's response? Upper motor neuron dysfunction, because I'm not able to suppress that primal reflex anymore. If I have a positive Babinski's, think something else. Think central at that point, because these are peripheral nerves. That whole idea of spasticity or plasticity goes out the window. All right, my people with Guillain-Barré, they should be afebrile and have no other systemic symptoms. If someone's febrile and they're presenting like this, I should be instantly thinking, hey, this is potentially meningitis. People with Guillain-Barré are not febrile when they present. That's why that's in there. Steroids are not helpful with these patients. There's a couple other disease states where they are. What we need to do is IV immunoglobulins or plasmapheresis. Can anyone explain to me what plasmapheresis is? Do we know that term? Have you been exposed to it before, or is that crazy talk? So plasma is in our blood, right? It's that stuff that kind of contains the fluid, and it has a lot of our stuff to include a lot of our antibodies. What we're doing when we're going through plasmapheresis is we're putting it through, filtering out all those extra antibodies and crap, and putting it back in, so we're reducing that antibody load, so we're reducing how much of that effect that we're having on our body by tamping down those autoantibodies you already have. All right. And then hospitalization, potentially with ICU, because these people potentially need to be intubated. All right, this is very common. I know that seems like not a lot, but you will see patients with this. It's a self-limiting disorder. That means it's relatively mild, right? Not all self-limiting things are mild. Originally, I thought that. I was like, oh, it'll go away on its own. It'll go away on its own one way. All bleeding stops eventually. Don't assume that everything that's self-limiting, there's still a lot of supportive care that needs to happen with these things. Most people get back to full. Did your relative end up getting back to full function? My guy ended up in the military within a few months to a year. Patients, they may need to rehab over a longer period of time because we're trying to retrain those muscles and allow that myelin sheath to regrow so we can duck better and we can move better without physical therapy. It has about a 5% mortality rate, so treat it seriously when Guillain-Barré. Don't send these people home without at least, you probably will be inpatient with diagnosed with Guillain-Barré. I don't think outpatient management's appropriate in many cases. All right, so we talked about the ADIP, the acute version of this. There's a chronic version of this, and I caught this and it made me look silly because I was like, oh, I had a patient with a history of Guillain-Barré syndrome years ago before he joined the military. I went, cool, that's great, welcome to the military. He's in with me for a couple of years. He develops a second episode of Guillain-Barré, and I call neurologists and I'm like, hey, I got a guy, I think he's having a repeat episode of Guillain-Barré. He did the S1 thing, the reflexes were completely gone. I'm 100% Guillain-Barré round 2. And he goes, there's no such thing. And I go, oh, crap. So in reality, Guillain-Barré doesn't repeat. What happens if we have a repeat episode and you're like, I think this is more of a chronic inflammatory demyelinating polyneuropathy. The CIDP is, hey, I'm going to keep having repeat attacks over a longer period of time. Your initial attack is going to be indistinguishable from Guillain-Barré. So my guy that had this, he thought he had Guillain-Barré. In reality, he had this underlying chronic inflammatory demyelinating polyneuropathy. He's going to have repeat episodes over a longer period of time. People with typical Guillain-Barré, we don't expect them to have repeat episodes. It's not a chronic condition. So Guillain-Barré, think acute, reaches, does anyone know what the word nadir is, or nadir? That's the lowest point of something or the highest point depending upon your orientation. So when we say the nadir of symptoms, that means, hey, the worst of it is going to be in 4 weeks. And then CDIP, progression over 8 weeks of a relapsing course. So that's going to be over a much longer time. For my guy, it was years, and he came back and he had a repeat episode. Why is it important for us to tell the difference between the two? Because in the treatment, this one actually responds to glucocorticoids. So think steroids for people that have the chronic recurrent thing. If I just have Guillain-Barré, do I want to do steroids? No, I'm thinking IVIG, I'm thinking plasmapheresis, reducing those antibodies. These guys actually respond well to Guillain-Barré. Or these guys actually respond well to glucocorticoids. Guillain-Barré does not. But glucocorticoids, response to glucocorticoids, I've said it 4 times already. I'm going to ask a test, I'm going to give it to you point blank. There's going to be a test question on it. I'm going to say it a 5th time, no I'm not. All right. Diagnosis is going to be clinical. I saw my guy, I knew it was Guillain-Barré just from talking to him, but it ended up being a much longer diagnosis. It wasn't that it took a long time to reach that conclusion. They had to rule everything else out because there were so many neurologic findings associated with it. Variable degrees of conduction slowing. Don't worry about the electrodiagnostics. They did that with him. They did the LP on him as well. I'm sorry, what's the question?
Could you clarify, is this only after they have a Guillain-Barré episode, or can this be like their...
The initial presentation, hey, you have CIDP? It's almost indistinguishable. It's very difficult to tell the difference. I couldn't tell you 100% for my case that I dealt with personally. I was like, he had Guillain-Barré. It turns out it was actually CIDP. It's going to be almost impossible to tell the difference until you have that second episode that says, oh, this is now a chronic issue. You'll see this with MS where you have to have kind of repeat episodes before you can reach the full diagnosis. So yes, I'll double check that to make sure, but I think that first episode is almost, I'll double check how many times it's diagnosed as Guillain-Barré for the first time. That's how it happened to me. So 1 out of 1 times. It's weird that it happened once. Yes, go ahead.
With this being a demyelinating condition similar to Charcot-Marie Tooth, is this strictly only lower extremities and then ascending? Like, can it also affect the other side of the pattern?
Typically with Guillain-Barré, you're going to see that ascending. It fits this very typical pattern. Don't think that every single demyelinating thing is going to follow this exact same pattern. It's the systemic effect that's causing it. In this case, you're dealing with your body having immune system attacking nerves and causing inflammation along the myelin sheath. The longer you have exposed, the more like that compounding effect is going to likely take. So the farthest things out have the most myelin affected before they reach you. Does that kind of make sense? Charcot-Marie Tooth is kind of a weird, everything can be affected. It doesn't fit a very typical pattern because it's a grouping of a lot of different, like very chronic neuropathies. Does that help answer the question, or does that raise more? Ish, can you rephrase your question?
I can follow my.
Oh yeah, I'll chat with you more. Thanks, man. Right. Glucocorticoids, glucocorticoids, glucocorticoids. There, 3 more times. All right. I got one more that I'm going to kind of keep in this inflammatory neuropathy case. Also an autoimmune neuropathy. It's called multifocal motor neuropathy. What's in the name? Motor. Does it involve sensory? No. Do I expect that in Guillain-Barré? Do I expect that in CIDP? A little bit, but this one should be strictly motor. Again, this one does actually respond to being on steroids. Nerve conduction studies, yes. IVIG, steroid plasma exchange, ineffective, sorry. So with this one, it's going to present very similarly to a Guillain-Barré. This one's a lot less seen, but again, we're going to have absolutely no loss of sensation with this one. And if you're kind of scratching your head, I made this lovely chart that allows you to differentiate them. Don't remember everything on this chart. I kind of highlighted and read the things that kind of clue me into something different. With that multifocal motor neuropathy, it's typically a lot more progressive over time as opposed to your Guillain-Barré. That's that rapid hours to days onset. And then CIDP, that can be that chronic relapsing multiple episode type thing. With that multifocal motor, it's going to be asymmetric. It's not going to be that typical ascending pattern that starts in one spot. Guillain-Barré starts in the feet, works its way up. CIDP, almost indistinguishable from Guillain-Barré clinically for that initial episode. Sensory findings. Multifocal motor, it's in the name. It should be only motor. We shouldn't be any sensory findings. We can see those kind of mild in Guillain-Barré and CIDP. Reflexes are normal in motor neuron neuropathy versus CIDP, Guillain-Barré, both of those need to be absent. And then which one do we like to use steroids for? CIDP only. Guillain-Barré and motor neuropathy, no steroids. It should be IVIG or plasmapheresis. And I might remove this from testable because none of you guys have had multiple myeloma yet. Is that correct? We haven't received this in either the juniors or sophomores. Okay. I will not test on this. I still need to teach you and expose you to it so you're not like, I've never learned this. But as for testing's sake, take a deep breath. I'm not going to ask you a question on something that you just straight up don't have yet. So we have this thing called multiple myeloma. What that can cause is it's a kind of a blood cancer related to our bone marrow. A lot of times these people will show up with lytic or diffuse lesions, really abnormal CBCs, and it can cause some osteoporosis and bone lesions. Typically, these guys can present with neuropathies as well. Am I going to expect to see a neuropathy and then diagnose someone with multiple myeloma? No, I'm going to have someone with multiple myeloma first, and I'm going to have a neuropathy show up later. That's the pattern that I want you guys to recognize clinically, because you may potentially have a patient with multiple myeloma. So know, hey, this person might have a neuropathy secondary to that. The other thing to pay attention to, because your patient's going to want to know, hey, is this weird neuropathy going to go away? Mild but can be severe, and they don't reverse after treatment with multiple myeloma. So that might end up being a permanent neuropathy. But for the sake of our test, because you guys don't know multiple myeloma, we won't ask a question on it. All right. Similar with vasculitic neuropathies, we don't know any vasculitises yet, do we? Kind of? What do we know about vasculitises? I'm tempted not to write a question on this. That was real fast. We don't have a good handle on this yet. Okay, no test question here. Just pay attention to what's going on. Know what I want you to recognize clinically. Again, someone with a vasculitis, that could be all types of different ones. Ischemic lesions to the nerve roots and trunks, motor sensory neuropathies. A lot of people with vasculitises end up having a lot of skin lesions that kind of look like this. It could track along, a vasculitis is an inflammation of the vasculature, the veins and arteries. Has anyone heard that term before? Or I don't know what you guys have been taught with this already, I'm sorry. I don't mean to teach down or above what you guys want to know. Know that polyarthritis nodosa is one of the most common ones we see. Do we know that term, or is that crazy? Yes, we know that one? I'm not going to test you on it, don't worry. If you guys don't know it, the sophomores don't. If we're not super comfortable on it, I got a billion other things I can test you on. All right, if I have a polyarthritis nodosa, know that they can present with this weird mononeuritis multiplex, meaning affected in different spots. Vascularly, our arteries and veins are being affected in very different spots. It follows that we have ischemic conditions in the nerves in very different spots of our body. For the sake of, hey, this mononeuritis multiplex, if I'm affected here, here, here in weird spots, and I have all sorts of weird skin lesions, say, hey, I think you have a vasculitis, and I think we're having a neuropathy because it's being affected in very weird and different locations. It's not following that typical length-dependent polyneuropathy pattern that I'm used to seeing. Are you guys okay with that level of knowledge on this? I know it's kind of weird where you're like, save it for later, we're not going over it, but you need to be exposed to it, and I don't think we've unpacked polyarthritis nodosa enough yet to understand it. Sophomores haven't been exposed yet, so we're not gonna hammer this one home and try to diagnose something we don't know yet. I appreciate you guys being patient with me on the weird ones. All right, I got a couple of neuromuscular junction syndromes. I got two. What's the primary receptor that likes to work in our neuromuscular junctions? Acetylcholine, and I got two different flavors, right? The nicotine version and the muscadine version. So the nicotinic ones, where do those ones like to work? The easy way to remember this one, what do I do before I go to the gym? Pop in a Zim pouch and go lift. So neuromuscular junction, it's the nicotine flavored one. Don't do that, sorry, that's not nice. All right, what does the muscarinic one do? Parasympathetic, very good. So do we remember the term sludge? I think we talked about that yesterday. Just keep that in your brain, that muscarinic effect. We'll kind of go over that as we move into some of the nerve agents. All right, we're going to cover myasthenia gravis, botulism, Lambert-Eaton syndrome, tetanus, and some nerve agents, and we're going to call it a day, guys. 4 more. So myasthenia gravis, you guys will see this for some reason. It just popped up during my phase 2, like 4 people in a row. And I was like, you're my 4th I may have overdiagnosed it. It popped up randomly. So what these people present with is ptosis, because that gets worse throughout the day. What really clues me into myasthenia gravis and test questions, both in PANTS and the real world, it typically gets worse throughout the end of the day. What's happening in myasthenia gravis is we develop antibodies to those weird little sodium channel things that are receiving the acetylcholine on the other side. So our acetylcholine, even though it's entering the neuromuscular junction, those receptors are covered with antibodies. They don't work anymore. So then throughout the day, more and more antibodies build up, and that works less and less. So typically, I saw all these guys in optometry of all places. It wasn't neurology, because they all had diplopia and ptosis. And it was like, oh, is this ophthalmology or is this neurology? Could be somewhere between the two. You'll see junctions with them, you'll see junctions with ENT a lot. Don't think, oh, just because I'm on ophthalmology, I'm not going to see anything neurology. So worsens with repeated use and improves with rest, gets worse throughout the day. Tends to evolve the face first, but it can be kind of progressive because, again, it is your immune system becoming worse and worse. Asymmetric ocular palsies and ptosis, variable paresis. Does everyone know the difference between paresis and paralysis? Which one would you rather have? Paresis, it's less severe. We're having some motor weakness, not quite working right. Paralysis, think floppy arm syndrome. It's not working too good no more. All right, normal sensation and reflexes, muscle atrophy late in the course. Most of these people we kind of catch early because ptosis and that double vision present pretty soon. You get a lot of headaches secondary to it. And there's some lab testing we can do. We can test for the receptor antibodies detected in blood. And we can do an EMG neuroconduction study. It can show impaired transmission because, again, that neuromuscular junction, it's not traveling through anymore. I'm not worried about damage to the myelin sheath. Break yourself off. This is not a demyelinating disease anymore. This is neuromuscular junction being involved. One of the things that's great test question material, it pops up every time, and it's actually important for what you need to do next with your patient. We can develop something, you know what your thymus is? Do you remember that one? It's like that organ that we don't really talk about anymore because it kind of shrinks up as we grow developmentally. And then these people actually will have a persistent thymoma afterwards. And that's what actually causes these anti-acetylcholine receptor antibodies to happen. So we need to make sure we do a chest CT on these guys to make sure we don't miss a thymoma. I don't know what percentage of it happens every single time because most of these people I saw in ophthalmology and they moved on to other worlds. So of the 4 people I saw, I don't know how many actually had thyomas. There's a couple of quick, easy tests. I actually did the ice pack test because I'm like, they taught me this in IPAP. I know what this is. And then I did it, and I was like, I don't know if that worked properly. So what you do is you take an ice pack and put it over the affected part for about 5 minutes. Then you see if the ptosis and the diplopia resolve. What we're doing by putting the ice pack on there is we're reducing the effectiveness of those acetylcholine esterase. That's that thing that breaks down acetylcholine, right? So now we're potentiating the effects of acetylcholine. We're trying to reverse that to see if it actually works. The other thing you could do is this tensilon test where you give them something called edrifodium. And this is a short-acting acetylcholine esterase inhibitor. So now we're causing those things to exist for a longer period of time in there. So it kind of counteracts the fact that those receptors are blocked. We didn't have that on hand, so I just did the ice pack and it worked. And they're like, wow, you're a genius. And I go, okay, cool. I don't know what I'm doing. All right, positive test, definite improvement with weakness when we give them edrifodium. There's a couple of different treatments we can do. We can give them acetylcholine esterase drugs, pyridostigmine. Have we ever heard of that one before? Do we have any CBURN guys? No CBURN people? That's strange. Okay. We'll talk about this one a little bit more. You'll remember it as a nerve agent thing because you're going to order it and do it with things. It's one of your nerve agent pre-treatment things because that affects your neuromuscular junction. Also works great with myasthenia gravis. Just remember that tie-in here because we're going to talk about it in 2 seconds. Thymectomy, so we can remove that thymus if that's the underlying cause of the issues. And corticosteroids can actually help reduce the amount of difficulty we're having with this. And then plasmapheresis again, because what are we doing by kind of filtering out the plasma? Trying to reduce that antibody load so it's not causing as many problems. Associated with small cell carcinoma because of that thymoma. We moved on to a different one. All right, Lambert-Eaton syndrome. This is kind of very similar to that. It's going to present very similarly to a myasthenia gravis. However, power steadily increases with sustained contraction. As opposed to myasthenia gravis, it gets worse and worse. The reason why it's causing that, it's caused by voltage-gated calcium channel antibodies, which leads to weakness, especially the proximal muscles. So that calcium channel, that's where the acetylcholine is actually released. So when we continue to hold that muscle and try to contract it, more and more acetylcholine is finally released. It still works fine on the opposite end of the junction. It has an association with small cell carcinoma, so pay attention to that one. Let's see. I have a comparison slide that makes it easier. Treatment is very similar because, again, we're given prednisone to reduce the inflammation and the effect of the immune system on these ones. And the response to anticholinesterase medications, so that edrifodium, that tensilon test, that's not going to work for us anymore because we're having a difficulty getting acetylcholine into the junction. Once it's there, it works fine. So even if we inhibit the enzyme that breaks it down, it's still going to have the same effect. It's not going to get any better. All right. Botulism. I haven't seen a lot of cases of botulism from food. I've seen a ton of cases of botulism or like the effects of Botox from Botox, meaning they do the injections either for migraine headaches or for cosmetic reasons, and it ends up traveling to places they don't want it to travel to. That's not much of an issue when it's kind of like limited to a very small area. It's more frustrating than anything else. If you get ptosis secondary to it, just protect the eye, do the normal things, but there's nothing you can do to really reverse the effects of that. When we deal with it being ingested, at what age can we start having honey? Who has kids? 12 months? Cool. All right, so for us, We worry about kiddos because they're a lot smaller, so they're a lot more affected by these things. Honey, canned foods that are bulging, these are all kind of causative agents for having botulism in it. This can cause double vision, blurred vision, lid lag, facial weakness, dysphagia, nasally speech, difficulty with respirations, limb weakness is the last sign. So if you get to the point where you're seeing floppy baby, things are kind of late. Think of the rest of these things, early clue, constipation and feeding difficulties. Think of those ones first. Always ask those questions, especially if you're seeing pediatric patients. Excuse me. Think of asking those questions first when you got a failure to thrive patient happening in front of you. Don't wait for floppy baby syndrome to happen. Recognize these things early by asking the questions of, hey, have we been feeding honey to Junior? Yeah, my whole family does it, and it's a 6-week-old. That's a problem. So the way we like to manage botulism when it's kind of that systemic issue, don't wait for laboratory confirmation before administering the antitoxin if clinical suspicion is high. Now floppy baby was given honey. It doesn't reverse the paralysis that is already established. It only binds the Botox that's still in circulation. And then aminoglycosides. So we talked about some different aminoglycosides. We got gentamicin, streptomycin. Be able to recognize those two. I'm not going to expect you to rattle off every single aminoglycoside and pick it out for a guy that's developing these issues. Aminoglycosides can cause some very similar effects to botulism. That wasn't a side effect that we talked about with these medications though, is it? No, because that's not a very typical thing. We don't give them a ton of streptomycin, gentamicin, and say, oh my gosh, they can't flex anymore. The time that we need to worry about these ones is those people that already have myasthenia gravis or Lambert-Eaton syndrome. We're treating them for other things, and oh, hey, I want to put you on gentamicin. That can potentiate and make these things much worse for those types of people that have that in their medical history. If I was going to ask a question about this, I'd chew it into, hey, this person has myasthenia gravis pending a thioma. I want to treat them with gentamicin. Should I consider that medication? Or I may give you a list of antibiotics and have you guys identify, oh yeah, that's an aminoglycoside. I should avoid that one. Or I could be nice and ask you what class of medication. Those are the kind of different levels. The fact that we're having a little bit of difficulty naming an aminoglycoside, that's okay. You guys aren't in pharm anymore. I'll limit it and try to keep it a little more neuro-relevant. I try to tease you guys when I'm like talking to you to see what you know and don't know, how much is like easily recallable, because I don't want to hit you with a train when we should be focusing on neurology. I don't want to make it too easy on the other side. We have trouble identifying aminoglycosides. No, we feel good about it? Mixed because we don't want to deal with pharmacology anymore? Me too, it's okay. All right, beautiful chart. This one is describing some of the differences of all those neuromuscular junction disorders. We got myasthenia gravis, so that's going to be that slow onset. Does that get better or worse with sustained contraction? Worse. Think gravis, think gravity. I'm fighting against gravity the whole time. And then what do I watch for with myasthenia gravis? What's the thing in the chest? The thioma. I want to make sure I get a chest CT to see if we actually need to treat that. Now this Lambert-Eaton syndrome, this is going to be kind of very similar, but what happens when I sustain contraction? Gets better, because right now we're overcoming those calcium channels. It's a difficulty with it actually getting in there. Once it's in there, it works normal. So the more I put into the junction, the better it is. What's the thing I have to watch out for? It's not the thioma anymore. It's still in the chest. Small cell cancer. Fantastic. All right. Botulism. It's probably a baby. Probably had honey. Pretty easy, right? If I was going to ask a question, I'd say, hey, do we wait for the laboratory findings or do we treat what's in front of us? And how do we treat it? We reverse the effects of the antibody. We bind that. I'll make sure that's pretty clear. And then aminoglycosides. We'll keep it limited to like, hey, this class of antibiotics. I'm being nice. I'm going to make it hard otherwise. Do we see that in general population always? Not necessarily. Do we have to be careful about prescribing these medications to people with myasthenia gravis, which is common? You will see patients with this. I have to be careful not to give it to them because then they're going to show up with even worse ptosis, worse palsies than they already have before. All right, tetanus, pretty common one, making sure we get our tetanus shot. Do you guys remember GABA? Do you guys remember glycine being the spinal cord version of GABA? That's what tetanus, Clostridium tetani is a bacteria that you guys probably remember from microbiology. You also know your tetanus shot because we're trying to avoid the effects of this. Is it always something rusty that causes the issue? No, it's just commonly what we get poked by that's actually like sharp enough to cause issues that's actually dirty. It's not rust that inherently causes tetanus. Soil can have it. So this irreversibly binds to the receptors in the spine, blocking GABA and glycine from affecting it. GABA and glycine are inhibitory or excitatory? Inhibitory. So if we get rid of that, we're going to become super spastic, right? We're going to look like this crazy guy right here. He's planking. He was the original planker. The smile right here, it's called the Rhizus sardonicus. It was because the people from the island of Sardinia smiled like that, and they thought they looked weird. In reality, I think they all just had tetanus. No, that was just their way of smiling. It's just people from that island looked like that when they smiled. All right, so it can take a variable time frame for this to actually intubate in people. It's not like I cut myself and I get it instantly. Anywhere between 5 days to 12 weeks for pretty far out for an infected wound. Sensorium is typically intact. This is entirely causing a lot of muscle spasm to the point of being locked out, very painful. And here we see a picture of someone kind of locking out. We see it affecting those peripheral nerves and causing upper motor neuron issues. All right. What we like to treat, making sure we're treating people for respiratory depression. We have this thing called tetanus immunoglobulin, TIG. We like to give that, especially even if we're considering it. And it only, kind of like the Botox reversal agent, this one only takes care of the unbound toxin only. Once it's irreversibly bound, it ain't coming off. So it's not going to magically, it's not like naloxone, it's going to instantly reverse it. It's just going to positively affect the course of it. But making sure we're doing TIG, making sure we're getting vaccinations back on board. If you get those puncture wounds and you're thinking of doing the vaccination, check when their last one was and go by the appropriate guidelines for how dirty it actually is. And then mortality rate for tetanus is actually pretty high, between 10 and 60%, which is a wildly wide range. But 95% of people that recover from that, they're not doing great afterwards. They're going to have a lot of long-term issues. All right, last topic for us, nerve agents. This is a fun one to end on. So, and I love how casual these guys are with like a huge like warehouse full of VX gas. Like I would have my gas mask on at that point. All right, so all nerve agents kind of work the same way. They cause cholinesterase inhibition. So that thing that breaks down our acetylcholine and causes our muscles to be able to stop contracting in our nicotinic receptors. And what does it do in our muscarinic receptors? All that sympathetic, parasympathetic nervous system, that sludge, that lacrimation, that diarrhea. It causes all those things to be unbound and cause even worse propagation of that. So with muscarinic, we're going to see salivation, lacrimation, urination, diarrhea, bronchorrhea, bronchospasm, meiosis, and bradycardia. All things that you don't want to have going on with you during a battle. And then for nicotinic, we're going to see fasciculations, weakness, and paralysis. And then with the CNS, we're going to see seizures, confusion, and coma. And it can cause organ stimulation throughout the rest of the body because of those that parasympathetic nervous system. I wrote down a couple of different names so you can recognize a nerve agent. Not so much I'm going to test on it because I don't think there's a ton of pants questions that are on that. But they're important for you to realize because your commanders are going to ask questions when you deploy, because anytime you go to CENTCOM, anytime you go to any area that has a lot of these agents that are in use, you have to know the things you actually need before you go. So VX is the one that's highly persistent, has a dermal exposure risk, and don't worry about writing down or learning these things. It's just so you can differentiate them out a little bit and just have something to grab onto. Soman is really concerning because it caused something called fast ACHE aging. Basically, it's impossible to have a window for this one because it affects your ACH so fast that those reversal agents never have a chance to work properly. So it's kind of resistant to some of those treatment agents. Sarin gas, highly volatile, it has a great inhalation risk. It's very easy to get it. Cyclosarin seemed less common compared to the other ones. And tabin gas is kind of one of those classic early agents. I called it the OG. Where's something that we might actually see patients with this in the civilian sector? So it's involved in a lot of pesticides. You'll see this in a lot of agricultural exposures. For whatever reason, farmers end up with some of the worst, most horrific injuries because they work with a lot of chemicals, they work with a lot of heavy machinery, and they don't come in until the other arm is off as well. With organophosphorus, that can cause very similar symptoms to these things because it's the exact same type of compound. This is why you should wash your strawberries before you eat them. So we got a couple of different treatment agents that we can do for this. Who remembers this pyridostigmine? What could we treat for that potentially? Myasthenia gravis, right? Cool. So we can give this as prior to exposure to nerve agents, and I'll show you a picture of what it looks like. That's that pyridostigmine there. I always thought it kind of looked like scary birth control because it comes in that pack that has a bunch of weeks by weeks. And if you're taking it, you're probably getting exposed to nerve agent. That's always a little scary. But you're taking one tablet every 8 hours. I just like the pictures because they're easy. It feels like it's a solid thing. But you're giving this out to your soldiers as a pre-exposure thing. Pyridostigmine, think pre-exposure. I will write a test question on nerve agents. Pay attention to whether or not we take it before or take it after. So pyridostigmine, we take it before we get exposed. The reason why we like that is it helps build up kind of a reserve of those ACH, those enzymes that break down ACH. So that way when we actually get exposed, we still have some left over that hasn't been taken over by the nerve agent. And this one's great because it doesn't interfere with military function. You're just having a bunch of Joes take the birth control now. But it doesn't cause you to get loopy or anything like that. That's a little different than your diazepam. So that diazepam autoinjector, you got to be very careful with those. Your commander's going to be like, oh yeah, give it out to the soldiers. We're going to carry it around, and you're not going to get any of them back at the end of the deployment because they have an injector that says diazepam on it. I like atropine. Who's worked surgery before? You know atropine? Do we give it to a ton of surgery patients? Not really that many? Don't like it anymore? Okay, so atropine is a good one. You're going to see this pop up during your surgery rotations. You're like, we're giving all these patients atropine. Atropine's great because it reverses the muscarinic manifestations. So that's going to reduce that bronchorrhea. That's going to reduce salivation. That's going to reduce how much lacrimation we have. Why is that helpful in a surgery patient? Secretions. We're trying to manage those things so they're not aspirating as much. Just remember, atropine used in surgery, atropine used in a guy exposed to nerve agents. And the last one is pralidoxamine, aka 2-PAM chloride is what most people call it. That protects your acetylcholinesterase from degradation. But if you hit that Soman gas, that one that hits really fast, we don't have time to protect them because they're already causing issues. But that helps bind some of the agent. And just so you can see what they look like, the things that we actually call them in military practice, I won't write a test question on this because that's outside of clinical guidelines. So we have that NAP, that nerve agent pyridostigmine pretreatment, NAP, scary birth control. We take it beforehand, gives us a reserve force. We have something called CANA. That's the one that's the diazepam autoinjector. That's the one that you give out to all the soldiers and then you never get back at the end of the deployment. And then the last one we have is ANA, or aka our antidote treatment nerve agent autoinjector. That's that pralidoxamine and that's that atropine in a single injector, 2-for-1. This is also called the Mark I autoinjector, but if you call it that, I think the last time anyone ever called it that was probably Vietnam, so they'll probably just look at you and say, how old are you? But just know CANA, ANA, and NAP are the 3 ones, especially in deployment scenarios. Your commander's going to look to you and say, hey, they're telling us we have to order a bunch of nerve agent stuff. What do you know about this? Oh, I remember I got neurology. I need CANA and ANA and NAP potentially. All right. I'll hang out for a couple of questions or chat or email me if you got any, but I appreciate you guys' time and patience today.